Now, maternal deaths. So this is all data. Now you can see that there are about 15 LGAs that did not report maternal deaths in either 2024 or 2025. Does that mean that mothers did not die from pregnancy and pregnancy-related causes in those LGAs in those 2 years? Children of God. Children of God. LGA vice chairwomen. Did mothers not die from pregnancy in your LGAs from pregnancy or pregnancy-related causes in 2024 and 2025? Okay, it is not being reported on the DHIS. So, the job of the panel, in fact, the panel has a lot of work to remind us what we need to do in terms of tracking our commitment to reducing maternal mortality year on year by 15%. Thank you. Do you have, okay, all right.
Thank you so much, Ma. I feel like you've already given an adequate introduction as to what this panel will be deliberating on. It's obvious that the data speaks and its voice is getting louder every day, especially in the health sector. There are many lapses that have been identified. Even while she was discussing, she talked about some disparities, in the different silos of data that we have collected. But essentially, we have considered this panel today to discuss the way forward with regards to data. Now, how is the data going to be aligned, or do I say realigned, to ensure that we actually hit this goal of 15% year-on-year reduction in maternal mortality? And I'll start my first question. I will direct my first question to Dr. Urangsa. Yes, sir. My first question is thus. Sir, please, how can we strengthen data literacy among PHC staff so that they can correctly interpret maternal and PHC performance dashboards?
All right, thank you very much, and thank you, listeners. First, we need to establish that data is life. When you agree that data is life, then we can start discussions from there. The first thing is, how many of us in this hall are alive? It is data. The first question, how many are here in this hall? How many are breathing? Assuming that some people are not breathing. So you establish that data is life. In every day, everything you do, you must use data to take actions. Coming back to your question, we have staffs in the primary health system. And the first question you want to ask yourself is, do they understand what data is? That's number one. So if you ask me, the first thing we need to do is to first of all identify the gaps. What are the gaps existing in the knowledge of those you entrust the management of the primary healthcare system in their hands? Once you do that, you will now identify those who need major trainings, those who need minimal reminders, and those who need your day-to-day reminder. Especially, of course, we know in public health, you need to remind and continually remind and remind and remind. It could be in form of training, it could be in form of talks. So for those who you need large number of trainings, you now begin to identify the areas of training. Is it the data tools that they don't understand? Is it the reporting pattern that they don't understand? How do you now improve that? Let me digress a little. Our biggest problem that we know, how many do we have that will form our denominator? What is our population? How many of the people that are sick in our entire river state or wherever we are operating? So when we don't have a denominator, bringing us here to come and discuss 15%, of what basis are you bringing the 15% to reduce? First of all, you need to understand, like the DHIS to showed clearly here, so many local governments don't have maternity deaths, mortalities. So, truly, are people not dying in those local governments from maternal-related issues? Number one question. So, when you understand that, you now start training your people to align yourself in that. Majority of them, people are not coming to the facilities. What are they doing that people are not coming to the facilities? Deaths are not reported even when they die in the facility. Why are we not reporting them? Could it be because of the tools? Or could it be we just feel that we don't want to report? So we need to align ourselves in those parameters and start working towards improving the data reporting based on what we have on ground. That's number one. Number two, I think I will use the phenomenon of what we call the iceberg phenomenon. You can apply it into data. The tip is what we are seeing. NDHI said we have 900 deaths. With in Rivers State, we have 500 deaths. That's what NDH said. If you go deep, you understand that we have more deaths. So it's only the tip of the iceberg we are seeing. The burden of the iceberg is still beneath. And it's something that is even wider and bigger than the primary healthcare system, that we need to use a multi-sectorial approach to see how we can solve that. I think that answers your question clearly.
Indeed, it does. Thank you so much, sir. Thank you very much, sir. I think if I was to summarize what you have said, the burden we have to deal with in the health sector with regards to maternal mortality is actually more than what we are actually reflecting in our data. And one of the fundamental ways to actually tackle that is to identify the problem, especially at the grassroots. And one of the major ways is also to ensure that we are training and retraining our staff in areas where there are knowledge gaps. Thank you very much, sir. My next question will be directed to our partner staff, the person of Dr. Deborah. Yes, ma'am. So the question goes to us: how can partners support a statewide data literacy curriculum? If you have systems already, you may talk about that. Or generally, what is your take on how partners can support a statewide data literacy curriculum?
Thank you very much, moderator. Just as Dr. Julian was talking and making the presentation on comparing maternal deaths reported via RIF-CHIP and DHIS, many questions were popping in my mind, and I think some of them have been addressed by SIO. The first one was, if people are dying, of course, when she asked the question, when she asked the vice president, right? Vice chairman, the question, when she said, are people not dying, are mothers not dying from birth-related, complications? They were nodding their heads. So, if these deaths are occurring, then what is the disconnection between these deaths in the communities and the nearest health facilities? There should be community linkage. It should be such that 2, 3, 4 mothers died, so months, and then the records get to the facility, and these records are imputed into the designated data tools. So first, we need to find out, like he has said, what the challenges are. Why are we not having that connection? Is it that the mothers or community linkers do not understand that they have to make reports to facilities? Are these reports coming and the designated officers who should put them down are nonchalant, or they know they have to put them down, they don't know how to use the data tools? So there are many questions involved. Before we start talking about attitude problem, where we can start talking about M&E frameworks, the question is, do they even know how to use data tools? Do they have the right data tools? Do they know what they are supposed to report? So that's, by the way, I was just trying to reiterate what the questions that were going on in my mind. Now, to support statewide data literacy, currently WHO does her bid by, when we carry out supportive supervision, when we move from one facility to the other, we carry out on-the-job training. There has never been a supportive supervision carried out by a WHO officer where we do not at least train health workers on data entry, be it DHIS, be it the routine RI data tools used in the health facilities, or the NHMIS data tool used by the HIOs and all of that. We go through these records, and on the go, we correct errors and train them. Now, WHO officers are few on the ground. Yes, we have a footprint across the LGAs, across communities. We have about 162 focal persons. We have about 56 field volunteers, 11 LGAs, and all of that. However, we will need more hands to ensure this impact is carried out across board all at the same time. So that is what we are doing, but we can also support in areas of funding, and I need to be very, very, I don't want to say careful here, because the states needs to make a request. Of course, WHO can only support the states to streamline her requests in areas of funding to enhance data literacy. Of course, if there is a training need, after we find out from the grassroots that certain health care workers who enter these data sets need training, they can come to WHO request for support. We can help them streamline their request and push this request to the respective quarters and help to secure the funding to ensure that this set of persons are trained. And of course, training is not the one-time thing. You have to do refreshers. Like he has said, little reminders, little IEC materials by the side of HIOs could remind them about the kind of data they should enter and when they should enter it. So if we can invest in all of this, I'm sure that data literacy in the state will increase. Also, we can support advocacy efforts, data-driven or data awareness campaigns, advocacy efforts by the states to help increase people's awareness about the importance of recording data, for example, like the maternal deaths. And just to digress a bit, when people ask, why do we have more campaigns happening in the north? We don't have more campaigns, campaigns happening in the south. For example, in the north, here we had OBRO 1, OBRO 2, and OBROs continue till December. In the south, for example, in Rivers State, we've only done 2, and I don't think we'll do another one until next year. It's simple. When there is a problem and you report, then funders see a need created and they come to help you. If you, for example, let's go to AFI. Sorry, I'm bringing that in. Adverse events following immunizations. We have serious and non-serious AFIs. As little as non-serious AFI is, little fever, redness, swelling of the site of administration of that vaccine, we encourage health workers to report. Just report. Let the national know that we have this happening. Nobody is going to blame you for it. Report. And when you start reporting and they start seeing data, they know there is a need. And then, of course, funders can come in to help out. So that is one of the ways we can help out. Thank you.
Wow, thank you so much, Dr. Deborah, for this eye-opener. In fact, if I was to summarize part of your closing statement, I would say maybe we are our problem, perhaps. Yes, because even the data we are not reporting is also impairing the help that could come to us. So definitely, the more we report the lapses, the gaps, as our able SIO had mentioned earlier, the more we identify them and report them, speak of them, perhaps the more help we would get from the partner staff. And emphasis on the importance of data training and retraining. I see that coming up, yes, more often than not. Thank you so much, Ma, for your contribution. My next question will be directed at the Chairman, MOH Forum, Rivers State, the person of Dr. KK Ramison, sir. My question for you is, how can the LGAs strengthen world-level supply monitoring and link it with maternal risk intelligence? I take that again. How can the LGAs strengthen world-level supply monitoring and link it with maternal risk intelligence?
Thank you, our moderator, for the question that has been thrown to us. Building on what has been said earlier, first on data, we know that data is key. Data is for us to get the right information, take the right decision. That means getting the wrong data, you are going to make the wrong decision. And you're also going to get the wrong results. And in regarding health that we are discussing now, every data emanates from the LGA. That means if we don't get it right at the LGA level, decisions will be taken wrongly at the state and at the national. And that now puts a very serious role on at the LGA level. And looking at the direction you have thrown your question, at the LGA level, first, we have a role to play to see that everyone that has to do with the data from the point of data generation understands the key performance indicators. The understanding of the indicators by all that has to do with the data from the point of generation is important. Understanding the tools is also very important. Understanding the essence for the data, because it's one thing to, okay, they want us to generate data, submit as you have done your work. Anybody can write any figure, put it together and send, forgetting the implication of what you are sending. So at the LGA level, you want to ensure that the people that are collecting data understand what they need to do through proper supervision, understand on-the-job training, but in doing that also we need to look at the fact that I don't want to go more into that in terms of the personnel themselves, the qualified, the requisite personnel that are to collect this data and enter. Because if you don't have the right personnel, even with your training, you are also not going to get the right results. You might see people filling anything they want, but you need the right people to be there to collect the data. Another thing, because I'm looking at maternal mortality, and we are talking about between now to next year, 15% reduction and all that. Every stakeholder must be brought in the know. We are dealing with community here because he talks about the denominator. If we are looking at the denominator, we are looking at the population, the target population. How many was the target population for an LGA in terms of women of reproductive age? How many are actually coming to the facility where they are to utilize the services of delivery? What percentage of our women actually delivers in the health facility? We have to look at that. And when we are looking at the data, if we look at the data that was presented earlier, we can see the high disparity between the pregnant women and those that actually were taken by ski bed attendants. The disparity is very high. It means we need to question some things. Why are our women not utilizing the services at the facility? And that comes us to community engagement. Community engagement, where we look at it and engage the community, get them to understand, and even the policy maker, like at the local government level, need to now understand based on the data available to us, get to the root cause, why they are not, and we have to reverse that trend. We will do this to reverse. So having said that, meaning that we need more engagement with stakeholders, community stakeholders. We are talking about the local government stakeholders, political and the other non-political stakeholders. And now at the facility level, the responsibility for the local government people is to make sure you supervise, get the required personnel, ensure they are trained, they understand the data too, enter the data too, and we also don't leave it as raw data. This needs to be analyzed, and we analyze this data, do a review, and come up with certain decisions or questions that the data before us has brought, so that we can take informed decision at that level to intervene. Could you need more community mobilization? Do you need whatever the data before you? When you ask question based on the data, you will get the answer, and you immediately drive in line with the process. So that is the area we need to look at if we are to get it right. Because even sometimes the data available to us, then are they the true picture of what is on ground? That's not what we're getting. You can have that as a data, it has been reported, but what is the real picture of things? And it starts from the point of generation. So all this we need to drive it and see that we get it right. Thank you.
Thank you, sir. So in line with that, can you just discuss a few mechanisms that can guarantee a rapid distribution of emergency commodities to facilities that need them on the LDA level?
That is very good question. I want to talk about it, but I believe you also raised it in the previous panel. But let me just go straight and address that particular issue. Yes, in the state here, even when they were making presentation from the DPS, you hear that, last mile distribution, which we know is not happening in the state. There's no last mile distribution, because that will guarantee getting it directly from the central store to the point of utilization. There's a problem. We need to strengthen that if that is where we are to go. Secondly, as it stands now, where you are talking about decentralizing the store, like now the NGO response to ensure that happens, there is no a store at the local government that actually is for the storage of those medications or the commodities to get to the last easy facility access. And you don't have also a focal personnel managing that, even at the local government level. So what am I saying? In order to see that there's no stock at, fine. Apart from the supervision, getting all the process, we need to remove the bottlenecks and say that there is a quick response in terms of getting these commodities available at the point of utilization. That means at the various facilities. So if we get the bottleneck out, ensure last mile distribution, decentralize the store, and ensure that facilities can quickly get access to the local government stores and get these commodities available to them, I can assure you that there will be no stock out, or even in the need of emergency response, you quickly get it sorted out. Thank you.
Thank you so much, sir. You've spoken so robustly on the impact or inputs on the local government level with regards to improving supply monitoring, as well as guaranteeing the rapid distribution in emergency. Thank you so much. All your points are noted, including ensuring that we remove the bottlenecks that exist, strengthening our last mile distribution, and of course decentralization, which is very important for effectiveness of any health system. So thank you very much, sir. I shall now be going on to my next panelist, the person of Dr. Clement Edet. Yes, sir. So, sir, the question for you is, what data literacy gaps exist across MDAs, and how do they affect performance management and KPI accuracy?
Thank you very much. That's a very good question. But first, let me address the issue of the health system, because we need to understand what the health system is, what the health system is expected to cater for. So you have a health system which everyone expects to promote our well-being, our health in terms of physical health, in terms of mental health, in terms of our social health, and not merely the absence of disease or infirmity. So if we understand that, the next question would be, what do we expect the health outcomes to be? For me, there are three things I expect any good health system to achieve. The first, to improve the health status of the population, the health status. So if we're looking at maternal health, you will agree with me. We'll be looking at maternal mortality ratio, maternal mortality rate. We'll be looking at antenatal attendance, which is more or less a proxy indicator. We'll be looking at a lot of other variables, even postnatal attendance, which is obviously very low in this part of the world. And of course, you will also be looking at life expectancy. Okay? Understanding that the reproductive age is between 15 and 49 years for a woman. So if you understand that we need to push for improvement in maternal health, so definitely we'll be looking at those indicators. So if you also move to the next one, which is our ability to satisfy our clients, client satisfaction and client responsiveness, which is very key. And I think the Honorable Commissioner alluded to that yesterday when she said that we have an improved satisfaction in terms of people who come to our health facilities. So we can actually see healthcare as a business, because most times we don't see it as a business. So we see it as a business, so we are likely to improve the quality of care. So if we improve the quality of care, it's very likely that we'll have more women coming in to access care. So we try to satisfy these women, we try to address their needs, we try to take into consideration their preferences, not just what we feel they should get. We should also learn to listen to them. Example, family planning. A woman that comes in for family planning, you need to counsel the woman, let the woman understand the different methods that are available. So that is really very core at the heart of what the health system is expected to achieve. And then lastly, we need to make sure, I can see that our executive secretary will be interested in this. So we need to be sure that we protect our women against catastrophic financial effects. What we mean is that if a woman is ill or sick during pregnancy or during delivery, she shouldn't sell her property or mortgage her property. I'm using that as a typical example because she might not be able to recover that property again. So we understand all of this and we juxtapose this with what the health system itself, the different layers of the health system. If you look at issue of human resources for health, do we have enough human resources for health? Do we have enough? So we need to look at that. We are talking about deliveries, but do we have that? We might not have. So that would be a problem. What of medicines? Do we have enough medicines? Simple hematinics or deworming medicines, can they even afford all of this? So if we look at the whole system as a whole, then you will now be able to know that we have a lot of work to do. It's not just about data. That's why I had to first of all discuss all of this. Now let's get into data literacy itself. So the question will be, what is data literacy? Because we need to understand what data literacy is all about. Data literacy is a huge box of stuff. First, do you have the policies in place? Do you have the standards do you have the accountability framework? Who should do what? What are the responsibilities? Can people understand data when they see data? Do they know what it takes to collect even data? Do they know what it takes to collect the data, to pick out errors if they exist in the data? So if we understand all of this, can they analyze data? And most importantly, why do we even collect data? Because a lot of us don't know why we collect data. When we collect data, it's because we want to base what we do in the health system on evidence. It should be data driven, it should be evidence based. So if people don't understand why they collect data, that will be the number one problem. And that is at the heart of data illiteracy. So if people understand why they collect data, I can see we have a mixed audience here, like the supervisors and other category of people here. So they need to understand why we collect data. We collect data so that we can better plan and implement what we are doing in the health sector. So that is very, very important. Now, so having laid this first layer out, we can now go into if data gaps actually exist. Yes, data gap does exist. And you do know that the health system is influenced by things that happen outside the health system. That's why we say this thing is a multi-level arrangement. Okay? From the individual to the family, to the community, to the health system, and to what happens outside the health system. For example, the Minister of Health is not responsible for road construction. Is not responsible for electricity supply to the communities. Is not responsible for road infrastructure. And all these things actually affect data collection. So that's why I'm talking about the multi-level approach. So if you want to address data gaps, it's not just about the health workers. Because even when you supply them with the tablets to collect data, if they don't have electricity, so the problem is still going to be there. So it's a huge envelope. So data gap does exist. But let us narrow down to what happens in the health system. And then we will talk a little about what happens outside the health system. So within the health system, when I was I have experience working as the medical officer of health. I have experience working as the medical officer of health. So I do know that a lot of people don't know why we collect data. They don't know why we collect data. I can tell you for free. So they joke with it. Sometimes the registers are there. They don't use those registers. They write on pieces of paper, either for reasons of defrauding the system. Because when they write on pieces of paper, they don't account for those clients they see. Example, antenatal patients, deliveries. They don't want to record them in the official registers. So it can be because they are not honest. So they will fail to record this stuff. Two, sometimes the materials are not available. That is, the tools are not available. If you check all our health centers, you might be surprised that they don't have all the registers. Because we have up to 14 registers. So sometimes they don't have all these registers in place. And because of that, of course, they will not report. Then the next thing is training. When I was the director of PRS, I noticed that some LGS like Okrika had over 30 health information officers. But Obiakpo, as big as Obiakpo is, and Port Harcourt, they had just 6 or thereabouts. So there's a problem with human resources for health when it comes to data management. Then the next thing, if you allow me, has to do with technology. We've deployed technology. When I was a team DPRS, we deployed technology. We made sure we gave all the health facilities phones. But I'll tell you something. Some of those phones never got to the health information officers in charge. They were either trapped by the head of facility or somebody higher than the head of facility. So those who were supposed to use the phones never got to use those phones. So these are the realities on ground. I can go on and on if you permit me.
Yes,
but
sir.
how do you solve this problem?
Yes, sir, for want of time, sir.
Okay, thank you.
For want of time, we appreciate your contributions. I feel like you have spoken so elaborately. I like how you came in from the health systems perspective and to let us know that our problems are actually multifaceted. But just for you to summarize, I had to interject to allow you to summarize because we have to manage time. If you had to commit one practical action from your angle, from being a former yes, sir. So if you had to commit to one practical action, what would it be, sir? Just to summarize, so that we can run through other speakers.
So as a former DPRS, what we tried to do was to develop a tool that tracks availability or non-availability of these registers. A tool.
Yes,
then
sir. If you can summarize in 1 minute, please.
Yeah, that's what I'm saying. So
yes, sir.
we develop that tool so we can track when the tools are available at the health facilities, when the tools are not available. Then data quality assessment. We ensured that we carried out data quality assessment on a quarterly basis. And so we had a baseline, so we could compare whether what we were doing was right or wrong. And so we use the DHIS, data from the DHIS, to compare what we found at the LGA level and what we found at the health facility level. So we were able to calculate accuracy, completeness, consistency, validity of the data, and all of that. So I think if we do consistent DQA, that's data quality assessment, consistently, and make sure that the tools are available, we will identify the gaps. Because once you identify the gaps, whether it is training gaps or whether it's a lesser attitude of workers, the DHIS will tell you, and so head on you can solve the problem. Thank you.
Thank you so much, sir. We will now be hearing from Dr. Bob Manuel, representative of the NHIA. So, sir, please, what data literacy capacities must be built at the LGA and facility levels to improve utilization of insured services? And while you are speaking on that, I would also want you to ruminate on one practical action within your mandate, sir, that you would like to drop with us. Thank you so much, sir.
Okay, good afternoon, everyone. My name is Dr. Bob Manuel. Thank you for this privilege. First of all, the recurring theme for this discussion is data is life, and it ranks as high as water, food, and air for some of us that work in that ecosystem of data. Now, the collection of data is serious business, and you must know what you are looking for. For example, if someone is asked to go and count everyone in red, you must understand the difference between red and pink. You must understand the difference between red and burgundy before you can even bring in data concerning those very red. Data has some characteristics. It must be complete, it must be accurate, it must be reliable, and it must be consistent. That the data you are producing now should be able to reproduce it. So now, the first step is the collection of data first. If you are talking about maternal mortality, the person collecting data on maternal mortality must first understand what is maternal mortality. Dr. Julian talked about the duration of for 2 days after termination of pregnancy and the death of a pregnant woman. It's beyond that. So the collector must understand that the woman dying must die from the pregnancy and its management, and not from accidental or incidental causes. For example, a woman undergoing antenatal care comes to the clinic, and on her way out she's hit by a car and dies. You don't want to record that kind of woman. So if the person doesn't understand that critical part, the person puts that one, and that data becomes unreliable. Now, going forward, now there are some basic literacy skills any data collector or analyst must have. The first is ability to understand the places to even look for the data. And that is where a good knowledge of EMRs and this DHIS we've been talking about, those are good sources. Then you must understand how to even look at ANC registers and look at disease trends, look at immunization coverages, because the essence of this data is to make informed decisions in interventions, targeted interventions, and also in allocation of resources. Where do I need more staff? Where do I need to send more money? Budgetary allocations. Those are the things that you need to do. Then another thing about what the person needs is analytical skills. Apart from the basic observatory skill, the person needs to know how to analyze data. And the presentation of data too is key. Don't just clump in numbers. One thing that will help is putting data in graphs and in charts, so that by just a single look or a stare, you know trends, you know what's going on, you know where to focus on. Then you should also understand how to present these things in what? Infographic ways. And then another key skill for literacy in data collection and analysis is what? ICT skills, where you have to leverage on telemedicine, you have to leverage on the EMRs, like I said. Then you should understand that there should be some form of legal know-how in the handling of data. Data is sacrosanct. Data in your hands is not to be shared on your WhatsApp status. There are data protection laws. So people handling data should have this first and foremost. Data is what? Sacrosanct. It's not something you share anyhow. Thank you. Then you talked about this.
One practical action within your mandate that you would most significantly, that would help the state in achieving that goal of 15%.
Okay, now from our end in the NHIA, we have so many intervention programs, and with our sister agency, the RIFSHIP, we have looked at CMOC. CMOC is what all of us know about. And for us in the NHIA, we have some pilot centers. We have UPTH, we have RSUT, we have the zonal hospital in Aoda, we have the zonal hospital in Okrika, we have the general hospital in Eleme, and those are the centers that women go to assess care for emergency obstetric cases free of charge at our level. And as at today, only UPT, let me use UPTH as a case. So UPTH alone has taken over, let's say 6 million from claims paid to them while attending to emergency cases. The figure is about 200 plus in River State. And we are looking forward to adding more facilities like CRC, for example. But now there's a bottleneck. Someone was talking about referral systems, and I was asking my boss here, how is RIFSHIP coping with the referral system? Is it just BMH? And I think there's a bottleneck because from the end of the HMB, they've submitted names of facilities to be accredited for secondary services, but till now, they've not come forth with their forms. So that is a bit of a drawback for us. So for these 5 facilities, as I mentioned, you can access care there, and that is our own bit in creating financial access to reduce maternal mortality in the state. Thank you.
Thank you so much, sir. And this question also goes to Dr. Urang and also to Mrs. Deborah. And that is, if you had to commit to one practical action within your mandates, what would it be in order to achieve the 15% year-on-year reduction? So we'll start with Dr. Urang in the capacity of Primary Healthcare Management Board.
All right, thank you very much. First, I'm not very comfortable with that 15%. The reason why I'm not comfortable with 15% is that you're making it your 15% on a projection, not on the actual. So if it is projection, and I'm telling you for free that our projection is faulty. So number one, we need to make efforts to actually have actual. What is our actual mortality rate? What is our actual coverage rate? Those things are very key. So we don't come to just tell ourselves good stories, we are doing well, and we'll clap for ourselves and we go home. Even as we're clapping for ourselves, deep down in our various minds, we know that what we're clapping for is not the real thing. And that's where data comes in. So for me, we need to make efforts to get the actual. How do we get this actual? Before we talk about the 15% reduction. Number one is, these sources where data are reported, can we make it real-time data reporting? We are using DHIS to whatever platform we want to use, though the National Council on Health has approved that the DHIS tool should be the only source that will report our health system. As it stands now, the DHIS tool is actually being entered at the local government level, which to me, it is not the source at which the data is generated. So pepper, salt, Maggi, everything enters into it. Now what Morga Dr. Edet said here is very key. We've been doing some form of what we call the DQA, data quality assessment, to see if what is being entered in DHIS2 or what is being reported in any other source is the same as being generated in that particular facility where this data is generated. So it actually boils down to how do we get this data that is reported at the facility at real time. So number one thing I want to do is for us to get some form of, how will I put it, let it have a human face, a data that has human face that is reported from the point of generation. The next question will now be, what is the quality of data reported at the point of generation? That can be discussion for another day. But let's have this data reported at the point of generation first before we go into the next story of what is the quality and how do we improve the quality. Because you soon stop me, so let me not go for that. Thank you.
Thank you so much, sir. But I feel like in one way or another, we've actually addressed that, the quality. I mean, if we focus a lot on the relevance of our staff at the PhD level, understanding the relevance of what we're doing, data collection, and also training and retraining, which I believe everybody has emphasized, then to a large extent, I believe that our quality can improve.
I have told you before that this is multi-sectoral. Multi-sectoral, like Dr. Edet has said too, it involves a lot of issues. This welfare of that health worker who is reporting the data, have you asked that person?
His transport to come to
now
work.
The next thing, somebody tells you, is it not data you people want? The person puts in the data, whether it occurred or it did not occur, person sends in the data for you. That is issues of quality. Yes. So we'll probably have a new section, one full day section to discuss quality of data. It's not just something we will summarize in 5 seconds and all that. So it is very important. But let's look at how do we get the data at the point of generation. If you give me money to do, that's the first thing I want to do. Let us get the data from that point of generation before we move to the next thing. Thank you.
Sir, please, I think Dr. Clement Edet would like to react. Just in 1 minute, sir, please.
Not up to 1 minute.
Yes, sir.
Just to add to what Dr. Rang said, when I was the DPRS of the River State Primary Care Management Board, I remember we got a grant, and part of the things we were able to achieve was to get to the point where we could get near real-time data collection from the health facilities. So we were able to achieve that. And we were able to get phones for all our health facilities. And at the national level, effort is made currently to make sure that data can be reported directly from the health facilities, because that enhances accountability and deters people from fraudulent activities, and also checks absenteeism from work. So I don't want to talk too much. Just to tell you that we've attempted to do that in River State. I don't know whether that is still being practiced. We even deployed unstructured supplementary service data to collect data not just from the health facilities but from the communities in case people don't have the smartphones. Thank you very much. I don't know whether that still happens here. Thank you.
And to wrap up this session, Ms. Deborah Omogbai, if you had to commit to one practical action within your mandate, what would it be?
Okay, thank you very much again for the opportunity. We have gone round this, I think they've even answered the questions. But in addition to getting data at the very source of data, where data is generated, and also reducing the middleman effect, such that data comes from the HIO at the facility and it hits the server straight. It doesn't have to go through anybody who may have tendencies to want to clean it or panel, okay, let me not say clean, but panel beat it, you know what I mean? And then making it look good, instead of giving us the real state of what is happening. In addition to that, I know that at the LGA levels across the states, we the state carries out harmonization meetings, data harmonization meetings at the LGA level at least once in a month. I don't know if that happens all the time. And we support the best we can. But do we have data harmonization meetings at the health facility levels, in facilities, before the data leaves to the LGA level? If the house is not clean, which data are you transmitting to LGA level that will now get to the server where data will be harnessed? When I was a routine immersion focal point for Bayelsa State under WHO Gavi some years back, you are aware that Bayelsa is a CERIC state, one amongst the 8 CERIC states. There's a strategy they employed that worked for them. Right there at the facility level, the RI focal person sends the number of children immunized per antigens per section via SMS. You don't need an Android phone. You don't need an Android phone for that. As to say, because of course if you have an Android phone, you could be working in a health facility where you have network challenge. You just send SMS. The SMS is properly coded and sent straight to the server, or sent straight to the server room. The person there collates it, analyzes it, and we're getting the exact picture of the number of children immunized per sections from all the facilities across Bayelsa State. As little as that is, it can make a difference. It's from the source. It's not going through a middleman. And to add to his point, when your denominators are not even, I don't want to say they are correct. When your denominators don't have a human face, let me use his words, which outcomes are you looking for? So let's fix our denominators, fix the middleman effect, and we'll get our data. Probably we cannot start talking about getting our 15% targets done. Thank you.
Thank you so much. Before I wrap up this panel, Dr. Urang, in 1 minute, please, react.
Less than 1 minute. Just want to share a little experience with JSI. They have a grant to run immunization outreaches in Rivers State for 1 year. And we had to come up with this issue of reporting data from the source of which this data was generated. And somehow we developed an app that we're going to test run in 9 local governments. And within the 1 year, we'll see how far we have generated data. It will tell us first how much children vaccinated, how much vaccines were used, and probably you can use that to extrapolate the estimated population in those places, and it will have human face. At least we can use that one. When we use that, we can now come back to say, what is the 15% of that one? Then we can discuss the 15%. But at this point, I think personally, thank you.
Thank you. Thank you so much to all my panelists. I think we have done justice. Yes. You still want to... Okay, please, let's just take our closing remarks, please. Very short, very short.
It's all right. Thank you. Just in addition to what they have said, because real-time data collection, we do a lot to solve our problems. However, to achieve that real-time data collection, just as you have said, the human resource, the HIO, must be available in the various facilities every day to transmit the data. It's one thing they said they got phones, even presently beyond phone, they even have made available laptops. But your question is not, that will not still solve that problem, because as it stands now, you have several facilities without a health information officer that is present. So you must ensure that that gap is filled. Let us have UHIO in all the facilities and have the requisite manpower in all the service delivery units. The moment that is happening and we have all the apps and the available equipment for real-time data transmission, I think we will get it right.
Thank you very much, sir. Just a short closing remark, ma. Mrs. Deborah.
Okay, by way of a closing remark, I just want to say that there are different training models that can be used to address different challenges in different facilities. For For example, if you decide to we probably hold a Zoom meeting, maybe a short course for health workers within Obiakpo and Port Harcourt. I doubt that model would work for health workers in LGAs without good connectivity. And I know that many years ago, and I think currently, there has been this pair-led learning where health workers, especially in the routine immunization space, hold weekly sessions where they teach themselves using the basic guide for routine immunization. Now, the question is, do we, are such approaches still in play? If such approaches are not in play, they should be reinitiated, because just those little drops of water can help remind them about the importance of data and data reporting. So I thought to let the House know that. Thank you.
What do we say to our panelists? And what do we do for them? If I knew that the SIO will not agree with me for this 15%, I would not have invited him to be on this panel. But no problem. A jar is for honest reflections and conversations. So please give them a round of applause. The Executive Secretary of the Rivers State Contributory Health Protection Program, here representing the Honorable Commissioner for Health, has a few things to say to all of us before we release my friends on the panel. Thank you.
Thank you very much, and good afternoon again. I wanted to say on behalf of the Commissioner that I like the conversation that is going on. I like the back and forth and the banter. And like Julian has said, that is why we're here. This is not just a talk shop. I believe that at the end of today, we would have actionable steps to take. Data is king, and it's all over the place. So we all know. I was just trying to draw something from what Dr. Keke said. We don't have the HR. We have all agreed. And I recall that during our panel, I had said that what the health insurance is there to do is to provide some catalytic funding. So you're getting funds every month as capitation. If you don't have a health information officer, why can't you get someone to play that role? And you pay the person a stipend from that. It might interest us to know that at Reef Chip we have only 13 staff. Do you know that? And we were deployed with just about 13 staff. But as I speak with you, I have over 70 persons that work with me. So you won't say until the government employs all the HRO that we need, then we are not ready. So the funding that we have, especially at the primary care, is to provide for human resource. It's one of the three pillars for primary health care, to provide essential medicines, to provide basic equipment. So that facility with that direct funding has been empowered to take care of these things. So HIO, and I know some health facilities that bring people to do the work of HIO. You train the people, it's data. You train them, it's the same thing. And get the information from the source to where it's supposed to be. They may not have access to the DHIS, isn't it? They may not. But at least at the level of the facility, they can make that data available for the LGA person to either come and pick up or whatever the modality is. So I'm saying this to say we mustn't wait for everything to be perfect. It's not going to be perfect anytime soon. But what actions are we going to take leaving this place under the present circumstances that we find ourselves? What can we do differently to change the narrative? If not, we'll come back here in 2026. We will not have a denominator. We won't have where we are going to. We don't even have the actual number that we're trying to reduce. So I want to thank you all for all of your engagements, and to say once again, let's give them a very big round of applause, and let's do a picture before we go.
Yes, please. So I'll be inviting the members of the panel to please stand for a picture.
Thank you. The executives, the honorable commissioner's representative will join the picture. Please give the panel a round of applause. Discussing data is never easy. Nobody ever agrees with any approach unanimously. Sorry, let me just, join. Thank you very much. No questions, no questions. Abi? LGA Vice Chairman, I will only listen to you people. You have question? You have. Okay, we have two presentations from the two biggest ogas in the room. But if you can ask your question the way you know how we do it, your name and what the Lord has done for you. Thank you.
Okay, good afternoon once again. I listened to the doctors concerning data. Now, I want to know, these data they are collecting, are they just collecting it from the health facilities? Or because health, generally, if you want to collect data for maternal and child health, if you want to get information, because I know that most of these pregnant women, they don't just deliver in the health sectors. If you go to, they usually go to TBAs, traditional birth attendants, you see them in spiritual homes where they deliver, and most of them dies in that process. So if while they are collecting the data, these data we are talking about, this your information here, is it just based on the data you got from the health facilities, or is it general data?
Vice Chairman, I just want to say that I love you. I want to profess my undying love for you, because flesh and blood has not revealed this to you, that our next panel session has to do with community intelligence, collecting data not just from the facility but outside of the facility. I love you, ma. So I will not allow any other person to respond, because we have a professor as one of the panelists who will address this question. By the time she finishes, she will convince and not confuse you that I love you. Clap for her. Clap for me. Thank you very much. So, before the next panel sessions, our very able executive secretary of the River State Contributory Health Protection Program has had her presentation delayed. Please, let's open our ears and our eyes and our hearts and listen to what she has come here to tell the whole of River State. So it is my honor, ma, to invite you to the podium to deliver the next presentation.
Thank you. While they're trying to put that up, can we just stand up and maybe just stretch a bit? Please. We've been sitting for a long time. Just on the spot, just do something on the spot. On the spot. While they're putting up that presentation, on the spot. Today we are not spelling coconut. Spell anything you like to spell by yourself. Just spell anything you want to spell. All right, so having done that, you may take your seats. You know, when you're presenting, when people are hungry, okay, you're not hungry. The Spirit has revealed that you're not hungry. People are tired. You have to do sharp. But I think it's necessary that we do this presentation so that some of the questions that came up concerning the River State Contributory Health Protection Program can be addressed, or at least you will have more information. So this is a presentation from Reef Chip, and okay, so this is not the right slide, but it's fine. There's supposed to be an outline, and there's supposed to be a title that says how Reef Chip fits into the Health for All Rivers plan. So the problem is that health is important, health is wealth, health, the reason we are discussing maternal mortality is because there is the Sustainable Development Goals, and we have Goal 3, which is Health for All. Health for All has a number of targets. One of the things we've talked about, maternal mortality has its own targets, and they don't want us to have more than 70 women per 100,000 live births dying. That's why we are looking at that number based on that benchmark, okay? Now, there's a target that talks about universal health coverage, and that's target 8. And universal health coverage is talking about everybody everywhere. And that's why I want to tell KK, in line with DPRS, that I love him, because he stood here and made my entire presentation and said that everybody in Rivers State needs to be on the health scheme, not just people that are vulnerable. So over 70% of Nigerians still pay out of pocket. That number is not supposed to be more than 30% of people that pay out of pocket. Can we have more? Prof, are you? Okay. I can pause. No, it's okay. It's my prof now. All right. And here in River State, more than 98% are still paying out of pockets. And it's a major concern. So, we've looked at the poor indices, we've looked at catastrophic health expenditure. We have stories of people that have sold their land to pay medical bills. They have sold car. You have one keke, your wife is pregnant, she needs a CS, you have to either go and mortgage it or sell it off to treat your wife, and then now there's nothing to use to make more money. And so that is the essence of universal health coverage, that talks about everybody everywhere having the health services and the Medicare that they need. And that health service is both preventive, promotive, curative, diagnostic, palliative, rehabilitative, all the range of healthcare services of good quality to be effective. So it's not anyhow health services. We're talking quality health services without going through financial hardship. And that's where we come in. That's why we are central to all of these presentations, because we think that Reef Chip is the solution, health insurance is the solution. And so if you look at this UHC goal, we call it an aspirational goal. Everybody, regardless of their age, of their gender, of their socioeconomic status, is everybody, and receiving all of this care, right? All this care of good quality, sufficient quality to be effective without going through financial hardship. So our role is to ensure that people can access quality service without having to pay out of pocket. So coverage is a concern for us. Quality of care is a concern for us. The service we are providing, and cost of care is also a concern for us. So I wanted us to just know that what we're running in River State is a social health insurance scheme. Some of us know about the HMOs and the private health insurance schemes. Those ones, they are usually risk-based. They will check your age, because with age, there are diseases that follow. They will check your lifestyle. Do you smoke? Do you drink? They will check how many children you have. So they assess your risk. Do you have underlying diseases and all of that? And you pay based on the kind of risk that you have. And, you know, so for us, what we do is a social scheme. It is a government-led scheme for us in River State. It requires mandatory participation. There is also what we call subsidy by government, and cross-subsidization by those who can pay more, paying more, those who cannot pay at all, don't pay, and those who can pay a little pay. So you can see that we are managing it as a government, and it's a community-based kind of income. So the advantage is that the coverage is wide and resources can be redistributed, okay? And then low-income individuals can also be covered. Vulnerable groups can also be covered. So, why does it matter? We protect families from catastrophic spending. We promote equity, because if we have a system where only those who can pay, then those who cannot pay will not have health services. Okay? It reduces out-of-pocket expenditure. You recall, sometime, is it last year, there was someone that died. There was someone that died because the family was not able to bring out the money. They had the money. They had the money. But I think they went to do POS to pay. Before they came back, the person had died. I remember that hospital was shut down last year because of that. So sometimes you have the money, but it's not readily there to bring it out, and that can be a problem. Timely care seeking or improving health seeking behavior. Some people are not going to the hospital because they think it's expensive, because they don't have the money. Our vice chairman talked about women going to take care to prayer houses, TBAs. It's because they don't have to pay immediately. They can pay with plantain. They can pay with a basin of gari. It's not the same with the health facility, okay? It provides a structured access to quality care. We talked about primary care. If the primary level is not able to provide, they refer you to the secondary and then to the tertiary. And it drives our progress towards UHC. Also, why what we are doing in Reef Chip matters is that it helps us to drive towards the universal health coverage goal, which is a global goal. If River State has universal health coverage and Abia State has and all the states have, then Nigeria will be gearing towards UHC. All right? So Reef Chip was established by law in 2021 and became operational in 2024. Okay? We operate the Basic Healthcare Provision Fund. Thank you, Dr. Bob. I saw Bob here. We started with that, and now we have expanded to the informal sector, and soon and hopefully next year we would expand to formal sector. These are our core values. The A is accountability. So when we started, of course, we were in the Ministry of Health, and then we were moved, a few of us, to go start up the agency, and we came up with a vision, mission, core values. These are the things that drive us on a daily to work and to deliver on our mandates. Okay, these are organogram, our funding. These are the funding. We got a small grant as takeoff, and then we get funds from NHIA, and we get premium from enrollees, and sometimes we get equity funds from government. And this is how our money is spent. You'll be shocked that I'm showing us this, so that when people hear that you have 1 billion, and some people here think that we have billions, even when we have the billions are for healthcare delivery. It's not for operational costs. It's not for, so imagine that you have 15,000 as premium for someone that pays 15,000 a year. There is nothing to even use and run around. Do you understand? So I needed to show that so that it gives some of us a picture, and hopefully to help to adjust the way we think and perceive the Reef Chip. Okay? So we have a fully automated system, ICT driven from end to end. So from enrollment to care that is given is documented. That's why we have data that we could share with the DPROS, because data is entered, pre-authorization code is requested for and approved before someone has to go for secondary care and all of that. And so far, in the last 18 months plus, we have been timely with paying capitation to the primary healthcare and claims management. We've been timely with doing that. Of course, we did facility assessment, all of those things to ensure that we had facilities, both public and private, that can provide services for us. And we continue to collaborate, to engage stakeholders, and to do community engagement. So these are our plans. And so with these plans, everybody in River State is covered somewhere. If you're vulnerable, you have the Basic Healthcare Provision Fund, which we have saturated. And if you don't make it there, you can be part of the Vulnerable Group Fund and the Equity Fund that the state pays for. And then we have some, we have for students, NHI relates with just the tertiary institutions. We are going beyond that to look at even primary and secondary, okay? And then the organized private sector, the formal sector, these are plans that we are exploring. Our informal sector plans, which are the private plans, we have basic that goes for 15,000 for now. At the end of this year, based on our actual studies, that will be increasing to 25,000. So I tell our local government people, this is the time to pay for large numbers of people, because once it is January, our premium goes up. The 15,000 we were using was not based on our actual analysis. It was because we were just starting, so we thought to start with something that people can begin to relate with. We get to see people testify about what they have benefited. That way they will be motivated to pay more. Because our household survey that SOML supported us to do in 2023 showed that people could only pay 5,000 naira per annum. So we were torn between 25,000 actual for the very basic package, 5,000 of ability to pay. We had to look for a middle ground to say, okay, let us do 15,000, especially because the Basic Healthcare Provision Fund package that we are using basically is quite comprehensive and robust, beyond what many other plans cover. Okay? So this picture is not showing everybody, but this is supposed to be the number of enrollees per LGA. This is where our vice chairman come in. If we can reduce that a bit, then I believe all of them will get to see themselves. Because it's just a few of them. But anyway, this is the picture. As a background, when we started, we decided to apportion based on the population of the LGA. So we had 68,700 and something lives for Basic Healthcare Provision Fund, and by leave of the government, we expanded that to 100,000. So we divided that 100,000 based on population of the local government areas. So each local government area was supposed to have some 2,000, some 3,000. I think Obiakwa was to have about 8,000 something. But we have even doubled that number as we speak. But if you look at these figures, you can still see that Bonny, sorry, because this is a screen, I think this doesn't work on it. Okay. You can see Bonny, 2,045, and that's because Bonny is the lowest, and that's because we started in Bonny this year. After a presentation like this with the then local government chairman at the time, the ones that left in February, the Bonny local government chairman, then a lady, asked that we come and begin in Bonny. We didn't start in Bonny because there is already a health insurance, a community-based health insurance in Bonny. And for us, we don't rob Peter to pay Paul. everybody everywhere accessing health care or being under health insurance coverage, it doesn't matter where you are per se. Even if we want you to come to our church, let me follow Julian, but if you are in Redeemed, it's okay because it's still heaven. So we shouldn't depopulate one denomination to populate another. That was our mindset at the time. As much as we wanted numbers, we felt they already had something on ground, which if they were interested in, they would have signed up to, and it will still add to the numbers in River State. We have people on private health insurance. I hope we know that. We have companies, we have HMOs. So it was after that they said no, that Bonny is missing out on what the government was giving, regardless of what they already had. So that's why we went into Bonny, and we have that number. But aside that, Omoma and Eche, Opobo, those have like the lowest, and Akukutoru. Now, Akukutoru has several interventions. The senator is already doing a scheme there that has about 1,000 or so persons in each of those 8 LGAs. But this is our own number, meaning that that number is not part of this. But when we look at the health insurance coverage for the states, we actually have that number to it. But what I'm presenting is RIF-CHIP data so that we can contextualize. So if we remove that, then you find that Opobo and Omuma, their numbers are still low. And so that's why we went to Opobo last week, and the vice chairman was graciously there to receive us and to listen to us and to see how she can support. So that's the kind of thing we want the LGAs to do. Like I said, yesterday we were at Ogubolo. Yes. So we'll keep doing that engagement. Maybe after now I'll reach out to our chair or vice chairs, and then we can see how we'll continue to engage and get our numbers up. So this is the picture of the vulnerability for the Basic Healthcare Provision Fund. So you can see children, pregnant women, all of that. You see the percentages, okay? And over time, our utilization have increased. Most of the presentations we see, primary healthcare is improving, emergency medical services, you know, their recording numbers is because of this enabler. And so you can see that hospital visitation is better because people are covered. When you don't have to worry about payments, that headache doesn't seem ordinary again. But if you don't have money, you have the headache, you say, that is how my malaria is, or let me eat, it will go, you know, and then you keep holding on to it, and then we present very late to the hospital. So what we've been doing a lot, trying to build systems, our PRS, they've done our documentations, AOP, all of that. Let me not bore us with that. Our operations, we have a 24/7 call center. We get calls, we redress them almost immediately. We pay capitation. I think now the average capitation we're paying to PHCs is about 70 million every month, okay? We have empaneled private facilities, and to speak to what Bob said, for our programs, we have already empaneled our general hospitals. Remember, RIF-CHIP is beyond implementing NHIA Basic Healthcare Provision Fund. We saw that gap. Regardless of the delays, we have decided to empanel our secondary providers because ultimately it will help us to bridge some of the gaps that we are seeing. So timely claims payments, we do 2 weeks, but we're hoping to be able to do better with timing, and of course we do all of that. We also have standards and quality assurance visits, M&E, all of those things. We do town hall meetings to get to know what our enrollees are going through. That's where we get feedback on stockouts. That's where we get feedback on some of the challenges we're having, because we are talking with our enrollees. We have a platform for our pregnant women, and so on a day-to-day, in fact, minute to minute, hour to hour, they are giving us feedback. Okay? We've continued to do advocacy. We've enrolled over 60s pensioners. We've started enrolling health workers. Right now, we are doing a lot of marketing in the informal sector. So our business development and marketing units, we are in all the trade fairs. This December, just go to any discount market, the one at Stadium Road, we are there. We are doing marketing because health is business. It's no more, oh, it's free. No. So we are doing marketing, we are spending money on visibility, on advertisements and all of that. Because if we don't do that and we continue to do the way we're doing, then the informal sector will not come in. Tomorrow is Universal Health Coverage Day, which is the 12th of December. Is an annual event, and for this year, the theme says unaffordable healthcare costs. We are sick of it. Who likes that? Unaffordable healthcare costs. We are sick of it. Everybody is sick of it because healthcare is not cheap. Quality healthcare is not cheap. What do people do when the economy is biting? People are looking for rice to eat this Christmas. How do they pay for their healthcare? So we are doing a lot of engagements, and we'll be here tomorrow. We're on social media. I will share all of that. Private facilities, we keep accrediting as they write to us and request to join us. Okay? Before now, we had just about 7, and they were working as our referral centers. So a number of achievements, but let's leave achievements. Everybody looks at challenges. So let me tell us that we also have challenges, just that we don't always bring them up. Our office space is from here to here like this. That's where the work you see is coming from. It's partitioned. I have very senior officers sharing office like bank, having, what do you call that? Workstations. So it means that something can still be done even with the lean resources we have. That's what I'm just trying to say. So that we are working doesn't mean we don't have challenges. Okay? We have numerous complaints. I forget about the beautiful presentations we saw here earlier. There are still germane issues that our enrollees are facing at the primary health care. But what we believe is that from these conversations, things will improve. Okay? We have all of these out of stock, blah, blah, blah. There are just so many things. But key gaps that we brought out that all of us here need to help us with closing. So you have our number is 100 and something thousand. But we have a population of how many? 9 million. So it means we are just what? A drop in the ocean. So where are the people? The people, some of them are civil servants and their families. But even when you put that, we've done calculation, it's about 250,000. It's not up to even 1 million. So the teeming population are in the informal sector. That is why we employed the aggressive media, social media, on-ground media, marketing. I mean, from this December, you will see our billboards everywhere. The way that Indomie is advertising, even when all the children are eating Indomie, we too want to follow them and do it that way. Okay? So we want to also automate enrollment. So with an app, you can do your enrollment. And currently, you can go to our website and be enrolled. We're also working on flexible payment mechanisms because now we're working with market women and men. We're working with schools. We're working with the NUWRT, road transport workers, and they want flexibility. They can't pay once, So we have started looking at how to make them pay instrumentally and work with the committees. We have also visited the Commissioner for Commerce, Commissioner PAMSEC, Ministry of Transport. Awareness. So if all of us here are aware and we take it to our different communities. Your community may be your hospital, your LG as MOH or VICE. If you know about this, KK said something, even you can register people. You don't need to wait for any political office holder. As a doctor, as just anyone, as someone that people call for medical assistance, as long as every time you're sending money, sometimes it's 20,000, that 20,000 would have solved an annual problem. So it's something I want to encourage us to do so that we can expand the population. At the joint annual review, we came up to 13th position, River State, and we were especially mentioned because, clap now, my prof is clapping, please clap. Because in the last 1 year, we did a lot of enrollments, you know. So let's keep it up, raise awareness. We are engaging call us to your church. Call us to your old girls, old boys association. Call us anytime. My team works 24/7. Even on Sundays, I tell them the work we do is ministry. I'm a minister in Reef Chip. Do you understand? So on a Sunday morning, if you call me to come and give a talk, then that's church for me, isn't it? I don't have to say I'm going to church. What is church? Sorry, some pastors are here. They may delist me. So, quality of care, we need to strengthen this collaboration because we are not providers. Our people go to primary health facilities, secondary facilities, tertiary. So we need to strengthen everything we're talking about, the data, quality of care. You know, we're talking about the community where they are going to. It's because when they come to the facility, either it's locked or when the woman is in labor at night, there's nobody there. That's why they go to other places because they register for antenatal. A lot of them will register, but they will always tell you in case. Then they will go to another place and then we allow that in case to happen because at the point where that woman is in labor, she comes and skilled birth attendants, because they are few too, you know, the person has worked all day. So you don't even know where to put the blame. All right? So out of stock syndrome, we're looking to last mile distribution and also having LGA level storage so that if facility A does not have a medication within the same system, does the facility close by have, does the LGA local government council center have, so that within that system we can run this. There's no point having medications, people are not really coming to your facility, and then you have things expiring on you. Meanwhile, another facility just around you needed it. So we need to have a system that we can manage our logistics, especially at LGA level, if not at ward or community level. Okay, so these are some of the things we've done. That's our office opening in March 2024. We did some visits. We went to prisons. We went to health centers. This is UHC Day 2024. Town hall meetings, a number of things that we try to do to ensure that the work keeps going. So on that note, I want to thank you. And thank you for clapping, but before you clap, everybody is holding their phone. Please just bring it out. If you're on Facebook, go to Facebook and search out River State Contributory Health Protection Program. If you're a Facebooker, there are people that don't do Facebook at all, but they do Twitter. So if you're on Facebook, look for our full name, River State Contributory Health Protection Program. Like us, follow us. At the end of this presentation, I want to see at least 20, 30, 40 people following us. Please, have you found us? River State Contributory Health Protection Program. If you're there, say aye. Click on it, like the page or follow. Thank you. If you are on Twitter, please, at RVCHPP, at RVCHPP. The I is not there on Twitter. If you're there, please do it now. I know that DPRS, go and sit down, DPRS. Sit down, sit down, sit down, sit down. Because this is part of the work we want them to do. Just sit down for 1 minute. Okay? If you're on Instagram, some of us is just the picture part. Instagram is at RIVCHPP. Please follow us, like us. Because you alone is a full community with all the people that you know. The more people that get to know about this, the more people will sign up. This is for everyone, for your adolescents, for your children, for your friends, even your enemies, because sometimes your enemies will give you problem. So tell them to register, or even register for them. Let them leave you alone. Our office is at Wing A, 2nd floor, Block A, Waterlines House, Aba Road. Thank you so much for your time. Clap now.
Permission to stand up, ma. Thank you, ma. Thank you. Please, no, clap properly. Clap properly. If not, you no lunch. Thank you very much. We at Reef Chip, we are running Bonanza. And the Bonanza will end on 1st of January 2026. So go now and register. Pay the premium of 15,000 naira, shikili money, now, before the Bonanza is over. Don't just like and share and follow. Buy the health insurance with shikili money for yourself, your husband, your boyfriend, your girlfriend, your house help, your son, your daughter's boyfriend, and your son's girlfriend. Amen? The next presentation has to go on now. I'm sorry, I'm disappointing my friends. Go and register with Shikini Money now, and I'll give you the microphone. It's next year. There's a waiting period, then annual coverage. Yes, ma. Thank you very much. So it's my honor to invite the representative of the Executive Secretary of the Rivers State Primary Healthcare Board, Management Board rather, to talk to us. Tell us something beyond his name and what the Lord has done for him. He has a presentation. Give it up for Dr. Okachi.
Good afternoon, Commissioner, ably represented by the Executive Secretary of Reef Chip. Permit me to stand on the already established protocol. I'm here to present our initiative towards strengthening healthcare delivery services in Rivers State. As we all know, the primary healthcare sector is responsible for providing healthcare services for about 70 to 80% of the population. And this we are doing across the 23 LG of River State. And we are leveraging on strategic services to drive improvements. And these activities that we have put in place to enhance the services of the primary healthcare facilities will start with the recently revitalized facilities, and this was actually done partly by the impact program, where 135 facilities were revitalized, but not all our facilities that required revitalization were included in the 135 facilities actually revitalized by Reef Chip. The board is currently revitalizing facilities that were not included in the Reef Chip facilities, and with equipment and solarization as well. Then for us to also enhance our services, we have some services that we also carry out. For example, the regular integrated supportive supervision stroke meetings that are carried out. Weekly integrated supportive supervisions are being done twice weekly, and this supervision has actually been strengthened with the provision of dedicated vehicles that carry our staff around our facilities to actually see the quality of service delivery. And when the supervisions are conducted, on the spot identification of challenges are made, then reports are eventually made to the board for onward action where necessary. They will also carry out the management supportive supervision. The board management actually includes the executive secretary and the directors, where they visit facilities regularly to ensure adequate service delivery. And in that visit, they interact with the local government authority to foster the importance of collaboration in the delivery of quality healthcare services. Then there are also monthly facility management meetings in our facilities. This is actually done under the leadership of the head of facility. In these meetings as well, challenges are identified, and the access to quality health are also evaluated. Then the staff are also made to comply with the standard, where solutions are also provided to our challenges identified at the meeting, with further reference to the board for relevant actions. Then we also have the technical committee meetings that are carried out in our local governments. The MOHs actually pilot these meetings, and in these meetings they actually make sure that challenges in our facilities are taken care of, with providing solutions to the challenges identified. Then of course the local government authority meetings too, which has been strengthened by the board. These authority meetings actually involves the LGA supervisor for health, the MOHs, and the community leaders. The activities of the facilities are actually discussed during these meetings, challenges identified and solutions provided. The outcome of these meetings generally enhances the quality of healthcare service delivery in our facilities. Then we also have a community engagement arrangement where WBC meetings are actually encouraged by the board, and it brings in the community group in healthcare service decision making, promotion of health initiatives in our facilities, and also creating awareness for facility utilization. Then the other services that we also provide, like the Maternal and Child Health Week, that is also being supported by the board and partners. And these services will include the family planning, where family planning activities are supported to ensure that they run smoothly. And of course, immunization services as well. You know, like in the board now, there is an efficient storage and distribution of vaccines are ensured with the recent provision of a solarized walk-in cold room at the board headquarters, and the provision of a dedicated push vehicles for the distribution of vaccines across the state. We also have sponsored immunization outreaches carried out in our communities to ensure that children are properly immunized, and with special consideration given for the hard-to-reach areas. Then of course the Maternal and Child Health Week activity. This activity is actually carried out biannually, and it's supported by the board and partners, and it's being done to strengthen maternal and child health care, and then also reduce the infant and maternal mortality rates in our community. Then of course the nutrition and growth monitoring for the under-5s. This activity has been intensified with the establishment of nutritional units in our LGAs, which now supervise and monitor nutrition activities among the under-5s to prevent malnutrition. And of course, disease prevention and control. This activity is also being strengthened by the board. Recently, there was this filarial infestation on the increase in Bonny, and the board actually went into action by providing medication and commodities that will enhance the reduction in that filarial infestation. And of course, offering support to communities with cholera outbreaks. Then the board also, in collaboration with partners, are also training our laboratory scientists on malaria microscopy, because most laboratory scientists are poor with actually malaria diagnosis with the microscopes. So some of our facilities now have gotten laboratory scientists trained to actually identify malaria on microscopy. And of course, disease surveillance activities that is also supported by the board, carried out by the MRE and the GSNOs, which has accelerated outbreak reports in the LGA. Then, of course, the quarterly review meetings that are also coordinated at the board with the support of partners has also ensured quality data collection. Then the quality improvement initiatives as well that have been initiated to ensure that our service delivery is efficient. We have regular audits and health workers building their capacity, mentorship, quality assurance programs are routinely carried out to improve the quality of healthcare service delivery in our facilities. Then we are also planning a patient feedback platform where patients now will rate our services and let us know what the challenges are and how our services were rendered in the facilities. Then we're also developing a standard operational procedure for all our facilities aimed at achieving a uniform health standard practice for our facilities and then encouraging quality service delivery. We have also introduced special programs like the basic obstetric scan services, the primary eye care services, the mental health services, and we're also about to initiate the primary oral care. Sorry, that was a mistake. It's supposed to be the primary oral care in our facilities to enhance oral care services. Then in the area of procurement and distribution, we have also strengthened our supply chain management with the arrangement for proper distribution and procurement of essential medicine and basic drugs. Essential medicine and the provision of basic medical equipment. This is done actually to respond to demands with adequate logistic support. Then the digital health system, we have currently engaged some of our facilities for the provision of electronic medical records. We are of the opinion that when this is actually implemented, our services will be improved and data collection from our facilities will also be improved. Then the staff discipline, which is also a challenge for the board, because in some of the presentations we've gotten here, we've also had a situation where patients who want to access care in our facilities and the workers are not there. Actually, the disciplinary committee of the board has been reconstituted for its effective action, where disciplinary measures against absenteeism majorly will be instituted on the recommendations of that committee. Because the challenges we are having in most of our facilities with absenteeism is actually coming from our workers in the rural areas, and most of them paid by the local government. That's why we are trying to work out a modality that will involve the local government in disciplining the staff. Because most of them, we don't have powers because we don't pay them. They are paid by the local government, they don't come to work. At the end of the month, they get their salaries, and it is a problem for us because we don't have the authority to discipline them. So we are working out a modality where such persons will be reported to the local government for appropriate disciplinary measures. Then our referral system actually has also improved with our collaboration with RIFCHIP. Because of the activities of RIFCHIP, we are now able to refer our patients to secondary facilities with little challenges. Then we are also planning a reward system in our annual facility review meetings, where we are going to look at the facilities, look at the best practices, look at facilities that are doing well, look for ways of rewarding these facilities and persons that work there to encourage them to do better, all to improve our service delivery in our facilities. Thank you very much.
Thank you please give the representative, in fact, give Rivers State Primary Healthcare Management Board a resounding applause. The truth is, most times we amplify the challenges and the gaps, but the greater truth is there is a lot of good in the system. We're just pushing for self-improvement and more improvement so that truly the Health for All Rivers strategy will be actualized. So we have to point out the areas that can be strengthened. And on that note, please give all the agencies of the Ministry of Health in Rivers State a round of applause. We are almost at the end. You know how when you're going to Lagos by road, once you get to Shagamu, you know that this is Lagos. You will surely enter it. That's where we are here now. We have a last panel. You know, you've looked at the agenda. We've seen breakout sessions. To the glory of God, we will not be doing breakout sessions. We will find another modality to extract the information we want from you. So after this third important panel, all the panels have been so far have been important. This is really important. Remember, I was declaring my love for the LGA Vice Chair of Ogubolo. I want you people to hear what the panel has to say so that you will know that I truly love her. Yes. And so the panel centers around addressing malnutrition and underreporting through community intelligence. The panelists will do a good job of breaking down that, but let me tell you something that you may not know. Recently, Rivers State has re-entered the news for the wrong reason as regards wasting. So we are amongst the top 12 states in Nigeria for wasting. So there is renewed focus on severe acute malnutrition. Yes, and so it's one of the things we want to try. We'll have the panelists talk about how to engage it by getting intelligence, getting information, getting data straight from the community and not relying only on facility level data. And so to moderate this panel session, just bear with us. I have my colleague and personal friend, Dr. Modukbe. How I know her is how I will address her. I know her as Modukbe Akinde. There's another surname, you know, when you marry, you throw away your son. I don't know that one. So, allow me to introduce to us. You are still Chief Resident, right? The Chief Resident of the Department of Community Medicine at the University of Port Harcourt Teaching Hospital, my personal friend, Dr. Modukbe Akinde. Please give her a rousing round of applause. I have begged her. I hear she's very strict. I have appealed to her. Take it easy with your panelists. Ejo, Mabinu. So, we'll do it like we did it before. I'll just let her introduce her panelists here present, and then I'll show you some data. The data is not a lot, but I think we should see it.
Thank you very much. Good afternoon, Commissioner, ably represented by Dr. Veti Agala, and allow me to stand on an already established protocol. As introduced, I am Dr. Modukbe Hoyadotsu. So Dr. Akinde, but now Hoyadotsu. So thank you very much. So I am a senior registrar, Department of Community Medicine, University of Port Harcourt Teaching Hospital. So this afternoon, by way of introduction, we are here to discuss something very important. And what are we here to do? We are going to talk about community health intelligence through local government insights into system-wide action. And so now, how do we go about it? I will quickly introduce my panels, and from there we take it up. So in our midst today, he's my boss, our consultant, my teacher, a mentor, in the person of Professor Homosive Madukam. So she is representing the Health Management Board here this afternoon. And also here is Dr. Didi Chukwemeka. He will be representing the LGA Health Authority, the local government authority, and also Dr. Smith Iworo, representing Rivers State Ministry of Health. So you are welcome. Other members of the panel are unavoidably absent. And so before we go, I'll quickly say across Rivers State here, the earliest sign we see doesn't come from lab. You know, when we talk about outbreak, that's what we want to talk about this afternoon. How do we, talking about community intelligence. So, and when things like that happen, we don't get information from laboratory or dashboard. We get information from mothers, maybe coming to tell us that there is unusual symptoms their children is presenting with, or from community volunteers, or also from our health workers. And so before we go ahead, we allow Dr. Julian to show us the data, some information, then from there we pick it up. Thank you.
The Honorable Commissioner and distinguished participants, thank you for staying up to this point. I just have 2 slides. Here, we are looking at data across the LGAs for mid-upper arm circumference of under 5 children. Sorry, I can't see there. Let me just stand here. Let me behave as if I'm on the panel. Over 3 years, over a 3-year period. So the mid-upper arm circumference, for those not in the health sector, mid-upper arm, for those of us with fat arms, if you take a tape to measure it, you get a reading when you go to your tailor, so that they will make your blouse and it will fit. Now in the health sector, children under the age of 5, when they come to the facility or when health workers go to them, they have a special device called a mid-upper arm circumference tape. It is color-coded, and they take this measurement to give them an insight on the nutritional status. So there are 3 codes, color codes: red, yellow, and green. If they measure your children less than 5 years, Abi? Yes. If they do that and it's in the green zone, it means you are healthy. If it is in the yellow zone, it means there is moderate malnutrition. If it is in the red zone, severe acute malnutrition. It is from moderate malnutrition that children go into SAM, severe acute malnutrition. And it is severe acute malnutrition that is reflective of the wasting, right? And we are number 5 in the country. Yes. We are number 5 on that list. So this slide looks at the data we've collected, I think from MSCH weeks, of children under 5 whose arms were measured and they were found to be red over 3 years in 2023, 2024, and 2025. For example, in Abua, they didn't have anybody in red, any child in red in 2023. That's why you cannot see a purple graph. But in 2024, you see a red graph. They had 3 children severely malnourished. And in this 2025, so far, they've recorded 5 children severely malnourished. And that's how it is, the figures across the different LGAs. You can see that in some years there was improvement, and in some it's undulating really. Yep. This is the other slide, and then I'll let the panel do its job. So this slide is dedicated to yellow, which is, what did I say it is? Moderate malnutrition. It means wahala, borderline. I mean, somebody's whispering borderline to me. Borderline. Meaning wahala don't begin today. Right. So again, we disaggregated this data that was collected in 2023. Yellow stands for 2023, red stands for 2024, and blue stands for 2025. I'm sorry, we are starting with Abua because in alphabetical order, right? In 2023, they had 129 children moderately borderline. What we do not know, because the data is not readily available, is what happened to those children. After they detected that they were borderline, did they tip over into SAM, severe acute, or were they nourished back to good health? And then in 2024, of course, the number reduced, which assumes that they were managed properly or they were lost. They didn't come back to the facility. And so it's like that. CLB in 2024, or in 2023, let's start with 2023, they had 81 children with borderline malnutrition. In 2024, it was higher, it's 548. In 2025, partly because there's been only one round of MNCH week, it's come down to 49. There are different ways to interpret this data, but the data is there and it exists, and it can guide policy making. So, on this note, I thank you all for listening to me, but it's time to listen to the distinguished panelists. Madam Moderator, over to you.
Thank you, Dr. Julian. Okay, so you are all welcome once again. Thank you for being here, Professor Maduka, Dr. Didi Chukwemeka, and also Dr. Smith Iroro. You are all welcome. So this afternoon, we are going to be talking about community health intelligence, turning local insight into system-wide action. And when we talk about community health intelligence, what are we talking about? We say this is the collective wisdom that emerges when communities share what they know about their environment, their risk, their behaviors, and their experiences. So we listen to these insights, and when our systems are designed to act on them, we gain the power to detect outbreaks earlier and respond faster, and also protect more life. So today's conversation is all about one central question. How do we transform community reporting, early warning, and local observations into a coordinated state system-wide engine for preparedness and rapid response? So that's what we want to discuss this afternoon. So I'm going to start with Professor Maduka, my great teacher. So the first question I'm going to ask you is that we have just a few minutes to answer. So please, let's just summarize our responses. We don't need to be too elaborate, but let's just go to the point so that we can manage our time properly, please. So the first question I want to ask is, what must hospitals report weekly that support outbreak analytics, just like the clusters, as in what must they report? What does hospital needs to report weekly that will help us to manage outbreak clusters, that will give us information about outbreaks?
Okay. I'm going to beg your permission to deviate a bit from your question. I hope I'm audible and clear. Because when we talk about gathering information and intelligence from community, that's where it starts from. So the first question should not be
at the community level. Now, what we should do is translate all these things to real-time results. Just to do some things in place, and those things are very simple. Now, at the community level, even at the facility level, we also have PSNO program person. Now, the difference between community and that of facility is that facility focal person is a health worker. The community focal person may not necessarily be a health worker, but is working for the health system. Therefore, at the community level, it is expected that when you meet all those outbreaks, suspicious outbreaks, disease outbreaks, you report in real time to the focal person who escalates it to the LGA. That's what we do. Then at the community level also, what is expected now to make sure that these things occur and then we don't have gaps, we need to enlarge it and make it a team so that we can have people like World Development Committee members as members. We can have people working the market women as members. We can have other people like religious leaders as members. We can have people in schools as members. Because if a child misses school for some time, is a suspect, there may be something wrong. There are people that dies in the community, nobody knows the reason why they died. All those things supposed to be escalated. And that is why I want to plead with the Honorable Commissioner for Health, represented by the ES, that every death in Rivers State should be reported. Whether it's caused by communicable diseases or not, every death in Rivers State must be reported to the LGA, who will now escalate it to the state. There are some deaths that need investigation. There are some deaths that does not need investigation. But the people in the community do not know the ones that need investigations and the ones that do not need investigation. That is why they should report all. That's what I want to plead with the commissioner. But now, at the LGA level, if those things are reported at the LGA level, we swing into action, investigate them, and escalate them, and then do other things that follows. So that's what we do. Thank you very much.
Thank you very much. Thank you for being brief. Thank you so much, Sam. Okay, so I want to ask that how can we integrate community signals on symptoms, deaths, clusters, and unusual patterns as early warning in the state? So what do we do in the Ministry of Health? So how do you integrate that into the things that we do?
Okay, thank you so much. Executive Secretary, representing the Honorable Commissioner, thank you for this wonderful opportunity. Most of us that know me here know me for one name, and that's MPCDSR. Our Vice Chairman here, MPCDSR means Maternal Perinatal Child Death Surveillance and Response. That program looks at giving value to life, especially with regards to women that were pregnant or have suffered complications, like one of our discussants said, that a maternal death is a specific death. It is not a death that a woman who was pregnant dies, but as a result of the complication of that pregnancy. And there's a time to it. So if a woman who was slapped by her husband slumps, it is not classified as a maternal death. And then the P of it talks about stillbirths. Our community don't look at stillbirths as important deaths, but they are deaths. Deaths that happen to children who don't get to live. And they have the right to live. So they must be counted. They must be investigated. And then we have the neonates, and then we have the under fives, of which Dr. Julian just talked about some severe acute malnutrition, which is a big thing in Rivers State. We are seeing more cases now. But MPCDSR looks at integrating and finding out the causes of these deaths, giving value, giving accountability to these deaths, giving a name. The truth is that sometimes many of those deaths come down as being unknown causes. But what of those that are known? We have seen for the mothers, A lot of mothers die from preeclampsia, which is the major cause of maternal death in Rivers State. Preeclampsia is hypertension in pregnancy. And it's something that can be easily handled. But because of this same fear, this same insecurity of handling your issues at a healthcare center, being afraid of spending so much money and taking shortcuts, our women continue to die. And as they die along with the children, giving us increases in our stillbirths, our intrauterine deaths. So, we've been having a lot of presentations with Summers. I know some of us that were here yesterday. He has talked about community informants. The gap, and we are going to bridge that gap in the name of Jesus Christ, is information, and the right information at the right time. A community member that hears that a woman is pregnant must ensure that that woman is registered. A World Development Committee member must ensure that all the pregnant women in his community are registered, and registered in RIF-CHIP. When they know that their pregnancy is covered, they will not run to any TBA, because they know that the costs have already been handled. A woman who has a child who is under 5 will immediately go there, because she's seen other children die from ordinary malaria. Malaria is a major cause of death in our under 5. This malnutrition we're talking about, pneumonia, and then we talk of these young children that are less than a week old dying from prematurity when they come out too early. These things can be handled. And then, like I have said, and I will continue to say this, we will need to expand our reach to the communities. The communities, you are the source of ending or reducing maternal, perinatal, and child mortalities in Rivers State. When you know what to do, when to do what you need to do, who to go to when you need help, these deaths will end. They will reduce to the barest minimum. So this is where we are. We will do the best we can at the State Ministry of Health. We are collaborating with all our MDAs, primary health care, hospital management board, RIF-CHIP, all the different MJs, the RESMATs, as we've heard yesterday, if you were here, they're doing an amazing job. We will do that, we will get better, but we need your collaboration. We need your buying. We need you to be ready when the time comes in. Give us the information. A woman is pregnant or a woman died. Let us handle this thing. Let us get this information. All deaths must be registered. Notification of all deaths is number 1. Every life matters.
Thank you very much, ma'am. Thank you so much. So in summary, before we just summarize, Prof talked to us about community engagement. It's very important. We shouldn't play down on that at all. So we need to go as health workers, as public health physicians, as doctors, as nurses. We need to go to town and get involved and also manage our information very well. So our community intelligence is very important. When people come, when they give us information, we should utilize it. And also, he talked about outbreak response to outbreak. And that is all, they have a system in place already. Once we have rumor or alert focal persons in the community that goes about, see what is going on, and come to the facility to report. And once they hear the report, they trigger action. So also, it is important that as community persons, as vice chairman, as World Development, CDC, World Development leaders, it is important for us to look out for people in our community. And we should report any suspicious disease, anything. And also look out to the vulnerable groups. That's the children under 5, the pregnant women. And she emphasized registration with RIF-CHIP so that they can have access to quality health care. So going to TBA to give birth is not the best because of the complications. But once they registered, once they have access to RIF-CHIP, it's free. And you can be guaranteed that mother and child will come out fine and well. And that is our goal. So it's important for you as community personnel to give information have relationship with the doctors in your facility, with the nurses, with the health workers. And the health workers too should have relationship with the community leaders, with the community members. They should have access to us as health workers. So that is how we manage, and that is how we communicate, and that is how we manage the community health, community intelligence. So in summary, Professor Maduka, do you have just last word, please, in 1 minute? Final word in 1 minute, please.
My final word is a question to our WDCs, our CDCs, and our vice chairman here. Do you know your medical officer of health for your local government? If you know, say yeah. If you don't know, say
They do. That's great. They do.
Do you know the medical officer or the healthcare officer in charge of the PHC that is in your ward? Do you know the person? If you know, say yeah. If you don't know, keep quiet. This is not as loud. It is your people we are treating. It is your constituency that we are looking after. You need to take up the challenge to know these people. Sorry, I know we are part of the people. Give us some heat and give us all the support. Give us all the support and make us accountable. Tell the market women, if you know anything that is going on, tell us. You can link them up with the health facility, healthcare workers, who you will now hold accountable to do something. If they don't do anything, just send MOH a message. See, we reported this. We don't know what has happened to our report. That way everybody knows that you are interested in providing us with what we need to give you the health care that we are supposed to give you. Thank you very much. You are wonderful people. Thank you.
Okay, Sam. So your final word, please.
Okay, my final word, the professor have addressed the community. I will take it back to the ministry and the health workers. Now, we need to strengthen our information gathering from the community. And that goes to show that we need to enlarge the team at the community level and also give them incentive for reporting. Because I have found out that the people you are asking to go and report, they are not even reporting maternal death in our facilities, but they are there. One even happened in my presence while I was supervising a facility. So they are all there. But I know why we are not reporting at the facility level. It is fear of punishment, fear of threat that they may be punished for killing a woman out of carelessness. That is the reason why they are not reporting. And so in our NPDSR, which we have established at the state level, it has not been domesticated at the local government level. I want to say that our NPDSR team should be established in all the local governments, so we can start reporting maternal and perinatal deaths. It is not to kill the people, it is for development, for us to improve in our treatment. That we are not reporting doesn't mean we are doing well. It only means that we are hiding information. Thank you very much.
Thank you very much, Sam. So Dr. Smith, your final word, please.
Final word. NPCDSR will be established at the local government area.
Thank you very much. I want to say a big thank you to the panelists. And today's discussion has made one thing clear. Community health intelligence is our earliest and most powerful line of defense. And when primary health care, when the PHCs, the LGAs, hospital data system, and other partners act quickly on local signals, we detect outbreaks sooner and we save more lives. And so it's our responsibility, everyone's responsibility, the health workers, the community leaders, the community members, to act fast when we see something. So if you see something, say something. Thank you very much.
What shall we say to the panel?
And what shall we do for this panel? So this distinguished panel, thank you so much. As with other panels, let us have the honor of having you take pictures with the Honorable Commissioner's representative, and then we will do vote of thanks and call it a day. So maybe we should go back so that, go on the podium, please. Yeah. When you're done with the first round, tell me so I can jump in.
Fresh.
Can I jump in? Thank you.
I cook fresh. Don't play. Oh, please, don't disguise.
Can we give the panel another round of applause, please? Yeah. Madam Commissioner, may I have the permission to do the vote of thanks and close? I cannot thank everyone who has stayed up till this time, everyone who stepped their foot in to this joint annual review yesterday and today. But I want to just contribute to what the panel has done by saying that to improve community intelligence, the Ministry of Health is designing a community reporting system that will launch the community or will support the community MPCDSR, so that, yes, no, don't clap yet. Let me explain how it is supposed to work before you decide whether it's worthy of clapping or not. So that this system, while designed, will leverage technology, empower WDC members to notify the state and LGAs of not only maternal deaths or neonatal deaths, but in addition, pregnancies, births, and deaths from any other causes, just like the LGA Health Authority on this panel suggested. We started discussing this plan about 6 months ago. It hasn't launched. We have to do a lot of due diligence. It ties into a greater Digital in Health initiative which the Honorable Commissioner herself spoke to yesterday. But there are many things in the pipeline, and there will be community reporting direct from the phones of the WDC members, who will be incentivized to notify the state and LGAs of these important happenings. And then the first layer of response will be the community health extension workers and all the stakeholders at that level. And then a second layer will be data officers who would validate, go to the communities and validate that data, triangulate it with what is existing, and strengthen community reporting, community intelligence for tackling public health issues. So I think, do you think it's something to clap about? Yes, thank you very much. I wasn't detailed to do the vote of thanks according to the agenda. It was supposed to be that of the permanent secretary, so I didn't prepare. But this has been the honor of my life to serve you in this capacity at such short notice. Every stakeholder we reached out to rallied and attended. It didn't matter whether you didn't receive an official invitation or you received it late. You came, you stayed, you gave your feedback, honest feedback. And the thing that we didn't do was the breakout session, which would drive data, all this data that we have gotten, to decisions that we need to take. We will design a tool and send them to you, and we crave your indulgence to answer the questions as you can, so that we'll get the data to strengthen our evidence-based planning system. So we've come to the end of the joint annual review of 2025. You will be served your meals here now so that we can close. But I think it's proper to do a closing prayer. Yes. Can we rise? Because truly, it is God that has kept us this far, not by ourselves. We could have been in different other places, honoring different other equally important commitments, but you chose to come here because of 9 million Rivers people who need quality health care. And so I don't know if it will not be okay to just say the Lord's Prayer as we close. That's, no, not the Lord's Prayer, Psalm 23. Yes. You don't want him to be your shepherd. That one is what we'll use. I'm a Catholic, I'm very sorry. Sometimes we pray with Psalms. And so I want us to close with Psalms. So Psalm 23 at the count of 2, please. 1, 2. The Lord is my shepherd. He restores my soul. He leads me in paths of righteousness for his name's sake. Yea, though I walk through the valley of the shadow of death, I will fear no evil, for thou art with me. Thy rod and thy staff, they comfort me. Thou preparest a table before me in the presence of my enemies. Thou anointest my head with oil. When I call upon Jehovah, surely goodness and mercy shall follow me all the days of my life. And we are praying for the house of forever. As you leave, only goodness and mercy will accompany you from here to your final destination. Amen. Ma, thank you so much.
So can I join you?
Shall we maybe?
Boys, stop this record now. Then back them up. Back them up.
How do we back up?
I'm ready backing up my own.
How should we have to back up? Stop streaming.
Back, when you finish. Where is your own mic?
Mike,
this
is Mike.
I was thinking they were going to send you off now.
Is it off?
No, I've not done it off yet. All this one's not part of it. That you deal with those. You've forgotten when you were making math. Honestly, I was praying. I've been praying. That's usually related. After that time, you did math. You say, what's the other? Usually related. You can go to math and say, okay. Since then, I've had it at heart that God, please give this girl up front. I want to go to North and I say yes, you can follow me to North and I was here and I say okay, NYC will give you North. He say yes, you go to North. I say okay, no wahala.